Hope everyone is doing well. Welcome to Chillin with Chitnis tonight. Hope you guys are ready to chill with none other than Dr. Chitnis herself, who has graciously agreed to hang out with us tonight and talk about what an ideal clinic visit with PD looks like. We get a lot of questions about how folks can maximize their time with their movement disorder specialist or their neurologist. And so we thought, why don't we have a dedicated session to that? And Dr. Chitnis was gracious enough to agree to do that. Just a couple of quick housekeeping announcements. First of all, for those of you who don't know me, my name is Shelley Korean with SkyPass Foundation. I think most of you guys know me. I see a lot of familiar faces here with us. We are recording tonight's session. So as a reminder, if you don't want to be on camera, go ahead and turn that off. And after Shilpa does her bit, we want this to be interactive. So if there are questions that you want asked, we'll open it up and you can, of course, unmute yourselves and ask questions. While she's speaking, I am going to mute everyone on my end. And so if you have a question, you can either unmute yourself or just send me a quick message and I'll be happy to unmute you. And with that, Shilpa, we're ready to chill with you. Let's go.
Wonderful. Can everybody see me?
We can see.
Okay. Okay, so hey guys, nice to see everybody. Thanks for being here. I think, when Shelley and I were talking about topics that would be really useful for patients, in addition to the topics that we talk about that are like pure knowledge, like how do you manage your meds or what are non-motor symptoms and how do you manage each one of them? I think that there are some practical aspects to Parkinson's care that we're hoping that will every other month that will bring those. I already interview a lot of people and we already have covered a lot of topics in the last 2 years, but there's still quite a few practical topics that really patients, like basically to know, because I think that if you know these things, then it might make your life much easier. It might make your, visit with the doctor better. So Shelley and I are really trying to do everything that we can to make life, easy for our favorite Parkinson's patients. So with that, I want to talk about just a visit. I'll probably talk for about 20-25 minutes and leave it open to lots of questions. So really, it depends on whether you're going in for a new patient visit or you're going in for a follow-up visit, because those two visits are different. Even in the new patient visit, there's nuances. So if you're going in with somebody that has new symptoms, don't have a diagnosis, your primary care doctor suspects that this could be Parkinson's, you're very nervous, and you're seeing a movement disorder specialist to get confirmation of your diagnosis, or your movement disorder doctor moved or decided to close their practice or something else, and you're looking to transfer your care to a movement disorder specialist. So all of these are, new patient visits, but they certainly have different nuances. I very highly recommend that if you are one of those people that has symptoms that are suggestive of Parkinson's, or you have a friend, most people here I know have a diagnosis, but somebody, you have a friend or a relative that has been told that they could have Parkinson's. One of the things that I really like for you to tell them is don't come alone. It's don't come to the visit alone. Bring a close friend, bring a spouse, bring a kid, bring somebody that's your support system. It is, again, as much as, we're all familiar with Parkinson's because we live in this arena, in this space, but really it's a, scary diagnosis. I think at the first time when you were diagnosed, and it is a scary diagnosis. And, our goal is to basically make it really simple and comfortable for all of you and make your life so easy that you're able to live the best you can in spite of the fact that you have a neurodegenerative disorder. And I don't like to put it like that, but for most people, we can run, but we can't hide. It's best for us to know what we're dealing with and then how best we can deal with it. So I really recommend for people not to go to a visit if you haven't had a diagnosis alone. I think it's really challenging. Even if you're transitioning over to a new doctor, I think it's a good idea to go with somebody, because it's still a new person that you're dealing with. Now, most people are very familiar with me because I'm always on social media or something. But if it's somebody you don't know their personality, don't know what kind of a person they are, what kind of time they have for you, what kind of bedside manners, it's nice to go with somebody that you can just squeeze their hand if you're nervous. So here's a very important thing. There are I remember when I was in Louisiana many, many years ago, this is when I was just starting my career. And I was trying to tell my uncle, who was a urologist, that, um, that here I am, I'm a Parkinson's specialist now. I just finished my fellowship. And, should I go into private practice? Should I just start my own practice? And patients will come to me because I'm so specialized. And he says, you think you're a movement disorder specialist, but every single neurologist out there that is practicing as a neurologist sees Parkinson's patients. So it's not like you're the only one who's going to be seeing Parkinson's patients. So you have to be able to know the difference between a general neurologist. So a general neurologist is a person that has completed 4 years of neurology residency. Now they could have a fellowship in something else. They could have a fellowship in headache, or they could have a fellowship in epilepsy. They could have a fellowship in neuromuscular disorders, but they're not a movement disorder trained specialist. But when you are in private practice in neurology anywhere, as much as you like to, the latest trend is for all practices to hire fellowship trained people who want to go into private practice, and so that they can internally refer, their specialized patients to them. But until you're building your practice, everybody sees everything. And so it's possible that you as a Parkinson's patient or somebody with Parkinson's symptoms basically landed up with a general neurologist that is not specialized in movement disorders. A movement disorder specialist, somebody like myself or my partners or many of my fellows who are, our UT Southwestern fellows who are here in the DFW area, have spent a year or two doing only movement disorders. So I spent 2 years, 1 year doing a general movement disorders and a second year doing lots of TBS. So 2 years of very specialized fellowship. I didn't see headache. I didn't see neuropathy. I didn't see MS. I didn't see Lou Gehrig's. I only saw movement disorders. And a large chunk of that is Parkinsonism and Parkinson's disease. So, and of course now 20 plus so many years into this, all I do is movement disorders. So there is a little difference that, somebody that has a lot of experience, so it's just not training, but also a lot of experience. And, you gain experience by doing something over and over again. Now you have to remember that at UT Southwestern or at most academic institutions, a new patient gets anywhere between 60 to 75 to 90 minutes. I think that number is getting shortened and shortened. When I started, it used to be 90. When I came to UT Southwestern, it was 75. But for the last, I think about 14 years or at least 12 years, it has been 60 minutes for a new patient and 30 minutes for a follow-up, which I think is, for somebody like myself who's so experienced, it's very generous. And, I can probably get, done if you had to really, plan a competition for efficiency. I think I can get done faster, but that's not my goal. My goal is to be able to get all the information, talk to the patient, counsel them really well, and when somebody walks out of my clinic, I really want them to feel like their visit was useful, that they got the right kind of information. And, I'll tell you, I am always running late. And I'm not running late because I'm lazy. I'm sitting and drinking coffee or getting a glass of wine or chatting with somebody on the phone. We just spend as much time with a patient as they need. And especially if it's a new, and that's just me, that, different people are different. So I'm just, everything that I'm telling you, take it in the context of how I like to do things. So we had a new Parkinson's patient on Monday, and basically, I didn't have any time because I'm always really busy. So I added them at the end. I knew them personally, added them at the end of the day. And we were there until 6:45. My clinic should get over at 5. But when I leave home and when I go home, I feel good knowing that, whoever walked out of my clinic really got something good. They feel comfortable. They have a degree of confidence that, although they're dealing with a disease, that they're going to be working with a person that has their back and is going to take really good care of them. So that's that, 60 and 30. But in a private practice, a new patient now, I talk to a lot of my residents who go into private practice. A new patient is 40 minutes and a follow-up is about 15 minutes. 15 minutes, I'm barely warming up, trying to just, settle in. And because I have the time and because I know my patients for a long time, I'll ask them, what have you been doing? Anything fun? Somebody had a new grandchild, somebody's kid's getting married. These things to me are part of the patient experience. It's not just like, how's your Parkinson's, here's your meds, here's your side effects, adios. I can't do that. It's just not my style. But you have to recognize that in today's day and age, doctors are really, really stretched thin. Reimbursements are bad. And so basically people will, make money, and the extent, of the money that private practices pay only if they see a lot of patients. They essentially eat what they kill. I'm a salaried employee. I make good salary, but I don't have to worry about, like, if somebody didn't show up or I spent, whatever time, it doesn't matter. So you have to recognize that, um, sometimes the experiences with doctors are not good. And I'm not trying to defend anybody. I think there are good doctors and bad doctors, or not so good doctors. Like there are good, engineers, and not good lawyers, and not so good lawyers. So you have to recognize that, that the reimbursements have really gone down. Medicare doesn't pay as well as it used to. And so they, anybody in private practice only eats what they kill. But my recommendation is, and I'm not trying to solicit business for myself or any of my, colleagues. I think they are really packed to the gills. But as a patient, you deserve the best. And so you need to be taken care of by a, movement disorder doctor. Or, the other reality is that, when I first started my practice, I saw everybody, I saw new and, follow patients. And when my practice got really busy, then I didn't see as many new patients. But now, with the efficiency metrics, with the the targets that we have to meet, even in academics for productivity, I have to see certain number of new patients. And so then my follow-ups are seen by, either my PA or my NP. But I will tell you that when our PA and NP starts, we don't set them free to see patients for at least 3 months. So they're kind of, doing a mini fellowship, with us. They basically rotate with us. They see patients with us. And it's only when we feel comfortable that I think they are well trained, that we let them go free. And even, they have the ability to basically call me and say, hey, Dr. Chitnis, can you help me with this? So I think that I will say that our PAs and NPs are really well trained, and they have the option of basically either, calling us, finding us, or saying, hey, can you see this patient for me? It's getting to be a little challenging for me. So we want to make sure that, every patient kind of gets the best care that they basically need. So that's the, medical economics of it. All right, so now coming to the actual visit. Okay, before you go, to see a doctor, and like I said, a new and follow-up visits are a little different. But I'm going to show you my screen so that you're able to see what my new patient. Shelly, am I able to share the screen?
You should be able to, and if not, I can.
Yeah, I can. Okay, so I hope everybody's able to see my screen. So I just, put this as a template on Microsoft Word in the afternoon while I was getting ready for this. So this is my new patient consultation. So I want to know what your chief complaint is. And sometimes it may be my chief complaint is I have Parkinson's disease, or it could be somebody that is new will say my chief complaint is basically, I'm not able to, my handwriting's gotten smaller, I'm not able to write as well. And then my wife tells me that I don't swing my arm very much. Somebody else may say my shoulders spin really stiff, I'm dragging my foot. So on and so forth. So, this is something that we document. And these templates are also made with, Medicare reimbursement in mind, along with, trying to gather, medical information. So the history of present illness is really important. So I'll give you an overview of what a new person. So patient I saw this Monday essentially was a person that basically, liked running and had difficulty with toes cramping and couldn't really run, and over 2 years of time slowly just stopped running because their toes were cramping. Talked to the primary care doctor, didn't know what was going on. So I'm getting their story from them. And then they said that, it was difficult, that they were trying to beat eggs and they couldn't really beat eggs as fast. And the kids noticed, or, family noticed, or friends, when they came over, noticed when they were serving things that, their movements with the right hand were slow. And so we explored that. Then we talked about, and asked them about whether they had any stiffness, because the main, cardinal symptoms of Parkinson's disease are, so if you have Parkinson's, the one thing you definitely have is slowness of movement or bradykinesia. So that's really, everybody has that. And then, of course, people may have stiffness. That's not stiffness as in arthritis, but that's stiffness in the muscles. It's also called rigidity. And then people can have tremor, but the tremor is at rest. So if I'm sitting, I'm watching TV, my hands are on my knees, I'm watching an action movie, something's happening, I'm at the edge of the seat, and suddenly my hand, starts going like this. Uh, so it's a tremor at rest. Up to 30% of patients with Parkinson's disease may not present with a tremor. And I know a lot of times that the patients don't come to see a neurologist because they say, I don't have a tremor, so I don't have Parkinson's. So you have to remember that, slowness of movement, rigidity or stiffness, tremor at rest are the three main, cardinal features. And people can have one, two, or all three of them, when you start out. And so exploring the story with my patient, they said, the handwriting. So I always ask about handwriting because the fine movements really get affected. Opening jars would be difficult, putting buttons would be difficult, tying shoelaces would be difficult. So I want to know, what are the things that you were able to do like a year ago that you're not able to do now? And so, and then the spouse will say, I think their facial expressions are not as animated. I think the speech volume has gone down a little bit. And if they don't tell me this, then I ask them. And then they'll say, I'm driving somebody, I'm driving and my hand's on the steering wheel, and then my thumb starts going like this. And so when I ask them, do you have a tremor at rest? And they say no. But then I ask them, tell me the circumstances under which you have a tremor, and it's actually at rest. So even, I remember a patient telling me, they picked up the phone, they were talking to their daughter, and their hand was going like this. And so they said, but it's an action because I picked up the phone. But you pick the phone and then it's near your ear. So this now becomes a rest position. So it's really a tremor at rest. And so then I recognized more and more that they were having some problems with their shoulders. I think this is a common story that, people go to an orthopedic doctor because they think they have a rotator cuff tear. And actually, it's just all that rigidity, and because of it, they're not able to move the shoulder. Then I ask about balance. I ask about, are you stooped? Are you stooped a little bit? Are you shuffling when you're walking? Are you dragging your extremity? Of course, if they tell me that the symptoms started 6 months ago and they're having a lot of falls, that worries me because I'm trying to explore, do they have the garden variety, what is called idiopathic Parkinson's versus what is, what can be atypical. So if people have some eye movement problems, they can certainly read, they can't, convergent read, they're having a lot of falls, or they're suddenly developing low blood pressure early in the disease. If they have really some cognitive issues, they're hallucinating and all of these things. So when I'm getting a history, I'm really getting a very detailed history to establish a characterization of Parkinsonism. I'm not zeroing in on Parkinson's disease yet. What I tell my fellows and my residents is broad umbrella. Like, what's the broad umbrella? And the broad umbrella is Parkinson's disease. And then the history that we are going to get will guide me to saying, I don't see any red flags. This looks like, really the garden variety Parkinson's disease, and so on and so forth. And then I ask them about sense of smell, speech volume, constipation. A lot of people get constipation many, many years before the onset of symptoms. Sometimes people have low blood pressure. Sometimes when people are sleeping, they're yelling, kicking, screaming, crashing. This is dream enactment that goes along with the, something that's part and parcel of Parkinsonism, which is REM sleep behavioral disorder or rapid eye movement, sleep. This is a stage of sleep behavioral disorder where the patient, really acts out their dreams. I'll ask about, any cognitive issues. I'll ask them about, do they exercise? Do they drink caffeine? I sometimes also want to know if I can establish an etiology or a cause of this. So I'll ask any head trauma, insecticides, pesticides, any exposure to that, well water, just chemical exposure. Some people basically, work with aircrafts and aircrafts fuel. And so that's, so I've basically gotten the whole history. So really in the history lies the mystery. And I really want to spend a lot of time getting the history. And so then I go on to past medical history. So somebody has diabetes, hypertension, so when you're going in for a visit, make sure, this was actually a template that I'm willing to share. Shelly can share it with you guys. And, this is something that you can populate, really put your past medical history. Family history, can be very detailed. Internist will take a very detailed family history. I specifically want to know if somebody has anything neurological. Do you have Parkinson's? Do you have essential tremor, which is, sometimes mistaken for Parkinson's disease? Or do you have, somebody that had, dementia, that died in their 40s or 50s, and so on and so forth. So the family history for me in context of, neurological disorders. Social history is, what do you do for a living? Are you still working? Do you smoke? Do you drink? Any drugs? Any, so that any surgeries, that's kind of important to have. Any allergies to any medications, because sometimes people may have tried, different, some medicines and have developed either a rash or developed, really excess sleepiness or something. So it's important to really know if they had allergies or adverse reactions to medicines. So this part is really part of my, really my history taking. And so once I've gotten this, by this time, I'll be very honest though, for somebody that has been taking care of people with Parkinson's disease for a long time, it doesn't take me very long to figure out somebody has Parkinsonism. When the medical assistant is basically bringing the patient, from the outside area to get their vitals and check their medicines and stuff. And if the patient's stooped, they're not swinging their arms, they're not blinking as much, or they have a tremor when they're walking, I already know, that this looks very Parkinsonian. But it is really important to do the due diligence to get the entire history, because I think that, one of my colleagues used to say, in the history truly lies the mystery. By this time, if I am not confident that what I'm dealing with is Parkinsonism, I got to go back to the drawing board and start talking to them more to try to get, additional information. So you can imagine that just this much story takes me, quite a bit of time. And then the exam is, really detailed. So I'll do a general neurological exam as well. I'll ask them to open and close their eyes. I'll look at eye movements are very important when you're evaluating somebody with, Parkinsonism. I want them to not move their head, look in one direction, look in the other direction, look up, look down. Then I want them to do quick movements, look to the right, look to the left, look up, look down very quickly. So these are called pursuits, which are the slow movements, and the fast movements are called saccades. And these can be affected in something like PSP, or they can also be affected in just Parkinsonism, that, movements can be slow. Facial expressions, speech volume. We have a unified Parkinson's disease rating scale. So it has 4 parts, but part 3 is basically the motor exam, which is very critical for me. I'll do a general exam quickly, because I don't want to miss anything else, because sometimes there can be other things that can, mimic, like Huntington's disease is one condition, another neurodegenerative disorder. If it presents very early, I saw a 17-year-old that came to me looking very Parkinsonian, and we did a full exam. And, if you see a 17-year-old person that is not on any medications that block dopamine, then basically, the top differential diagnosis is Huntington's disease, because it can present as Parkinsonism. That's why it's really important to do a really detailed neurological exam. And in the Parkinson's disease rating scale, the elements of that are facial expressions, speech volume, speech clarity. I'll have people put their hands out to look for postural tremor. I'll look for action tremor. I'll look for, tremor near nose. Then I'll have them put their hands on their knees and spread out their legs and count backwards from 100, which will basically help bring out, the Parkinsonian rest tremor. Then I'm looking for, slowness of movement. So these are really fine movements. Like I asked them to make a L and do these fine movements. And these are definitely affected, quite early in Parkinson's disease. And sometimes these are lost. And even my best treated patients, they do this, score 0, they do this, score 0, they tap their feet, score 0, but, they may be a little slow with the finger taps. These are the fine movements that are lost quite early. And that's why, handwriting is something that's also really affected. Then I'll check for rigidity. I'll move the neck, I'll move their, arms, both arms and legs, to check for stiffness and rigidity. Then I'll have them put their hands across and see if they're able to get up from the chair. That's also examining slowness and stiffness, especially in the back muscles. And then I'll take them for a walk, make them walk, just free flow, look at their stance, look at their posture, look at their arm swing, look how they turn, because turning can be affected in certain cases. And then I'll do a scary thing that's called a pull test. And the pull test is really looking for really balance or postural stability, and give them really good instructions and say, I'm going to pull you back and then, take a step or two back. I won't let you fall. In 20 plus years, nobody has fallen when I've done a pull test, and I hope that nobody falls, in the future as well. So I'm very careful, but I want to know what their balance is like, because, I think it's important to identify that early, because I can put them through PT, I can put them through big therapy. So, it's really important to identify not just medication management, but also what therapies a patient needs: speech therapy, occupational therapy, physical therapy, so underutilized. We have to use them, to be able to provide the patient the best quality of life. Sometimes somebody will come to me with a brain MRI, or sometimes people even have DAT scan. DAT is D for dog, alpha, Tom, which is a dopamine transporter scan, and where you give people a dye, and the dye goes and binds to the dopamine terminals, and we are looking for the uptake of the dye. And if there is reduced uptake, that means that they have Parkinsonism. A DAT scan or a brain MRI does not diagnose Parkinson's disease. When I get a brain MRI, it is to make sure that people don't have strokes, people don't have brain tumors, people don't have, there is a condition called normal pressure hydrocephalus, or NPH, where there is excessive fluid on the brain. I can see that on a brain MRI. If somebody's had a lot of strokes, that can sometimes, give rise to what is called vascular Parkinsonism. So I'm looking for that. But in atypical forms of Parkinsonism, such as PSP, or progressive supranuclear palsy, multiple system atrophy, or corticobasal syndrome, I'm actually able to see some findings on the brain MRI that are indicative that this could be an atypical. So those are the reasons why I get a brain MRI. I don't always get a DAT scan, because I think I better be confident about my clinical skills, that I should be able to diagnose, and even in 2022, the diagnosis of Parkinson's disease is still made with, clinical criteria. Somebody that has slowness, stiffness, or resting tremor, one or two out of the three, and then associated symptoms, as we talked about. Somebody has basically low, sense of smells reduced, handwriting, speech volume, constipation, dream enactment, depression, so on and so forth. So all of those things, give me a lot of confidence that this is, going in the right direction. So I'll review the test. I always like to show the patient, like, here's your MRI, this is what I'm looking at, this normal brain MRI, or if I see something abnormal, I'll show them. If there is loss of brain tissue, I'll show them. I'll show people a DAT scan, what it looks like. Now, remember, I do have an hour or more. So, I'm spending all of this time. If you go to see a neurologist in the community, don't expect any of this. They're not going to have the time, and they're not going to do that. Yeah. So, whatever I'm telling you is really in context of, being in a university setting where I have fellows and residents seeing other patients while I'm spending a lot of time with my, with my new patient. So I review the test, and then really, while I'm doing the exam, I'll sometimes walk the patient through. I'll say, look, I'll tell the spouse or who is look at this, like, oh, look at the right hand, like the left's going really well, but the right hand is slowing down, or a tremor is coming out. And so I keep demonstrating the exam findings to the patient while I'm doing the exam. And so when I come to write my, impression and plan, so generally my impression and plan will be, whatever 60-year-old right-handed gentleman with past medical history, either nothing or basically diabetes or hypertension, that presents to me for evaluation of possible Parkinsonism. They started with, I'll say, right-sided symptoms, slowness of movement, stiffness, intermittent resting tremor, postural stability is okay. Then the handwriting is affected. I found on my exam the speech volume to be low. And based on all this, they seem to meet the clinical criteria for diagnosis of idiopathic Parkinson's disease. I don't find any red flags at this point. I don't see any eye movement abnormalities. I don't, hear in there's some things in their speech, or I don't see, early postural instability or balance issues. I don't see any cognitive issues. Sometimes we will do a screening cognitive test, which can be a MMSE, which is a mental status exam, again a screening test, or sometimes we will do MOCA, which is a Montreal cognitive assessment test, scored out of 30, and that will tell me if the person is doing cognitively. Now, if the patient's giving me very good history, and I'm not very suspicious, I may not do MOCA at the initial visit, or may have the medical assistant do it, or the PA or NP do it at the next visit. So my impression will be that I think that this looks like Parkinson's disease. So this is a person I've never seen, a person who's never had a diagnosis. And then I'll say, well, but we still have to be sure that they respond to dopaminergic medication. So as you know, and this is not going to be a lecture on medicines, but the medicines that can be used, for new Parkinson's can be a MAOB inhibitor, such as rasagiline or selegiline, some people use, or dopamine agonist. I promise you, we're not using dopamine agonist anymore. These, if you have a friend that is 75 years of age, goes to see his general neurologist, and they recommend them to use pramipexole or ropinirole or Nupro, please tell them to not start these medicines. They have a lot of side effects: excessive daytime sleepiness, dropping blood pressure. If people have cognitive issues, or they're older, can have hallucinations. They can have, leg swelling. I remember a patient of mine, poor thing, that recently died, that I saw for the first time, had really huge looking legs with a lot of swelling, pitting edema, and pink and almost like ulcers. And I said to the guy, what medicine are you on? And, and I knew already. I said, which one? And I said, you need to come to my clinic. I got him to my clinic. I slowly took him off the pramipexole. It took 6 months for the leg swelling and the ulcers and everything to heal. These are really, really bad medicines. I don't even put, they used to be good medicines, but now over time, that the side effects are really bad. Worst thing, people develop impulse control disorders. They blow $100,000. They go gambling. I had a guy who was AA for 19 years, had not had a drink. I put him on a Nupro patch. This is a long time ago. And the guy started drinking again. And, people gamble, people go online and do pornography. I know people who've had affairs. Like I had a really stable, sweet 75-year-old guy that started, an affair online. So these medicines, the dopamine agonists, they stimulate the dopamine receptors that are called D3. These are in the part of the brain that's called the limbic area. The limbic area is reward and reinforcement area. And then people start doing all kinds of things. So really, levodopa, carbidopa, Cinemet, or Rytary, whatever formulation is really become, it used to be gold standard before, it's still the gold standard now. People used to be worried about, I'm going to get dyskinesias. Don't worry about it. The statistics show that 50% of patients at 5 years, 75% of patients at 10 years, and larger number even later, can develop some form of involuntary movements, can develop, motor fluctuations where the medicine does not last from one dose to the next to the next. If you're adequately treated from the beginning by a movement disorder specialist who knows what they're doing, they're not going to put you on large dose of medicine. They're going to give you a titration schedule that you're going to go up on the medication really, really slowly, and essentially, like, that take good care. And then I plan, what am I going to plan at today's visit? So I either order an MRI, if I sometimes that scan, then basically medications, explain to them what the medicine is, why am I starting this, what are the side effects, what do you expect? So it's really important when you start a patient on the medicine, you tell them, why are you starting this medicine? You have Parkinson's, you are lacking dopamine, I'm replacing dopamine. Many ways in which this can be done. Gold standard is levodopa. This is your titration schedule. What do I expect? I expect that, perhaps your tremor gets better, slowness gets better, arm swing improves. Okay. You can get nausea, you can get vomiting, you can get lightheadedness, you may get sleepy, you may get worsening constipation with levodopa. It's really important to explain to the patient, what are the side effects, and then if I do therapy, sometimes if I worry, wife says, his memory is not that good, I may put them through neuropsychological testing. I may basically, of course, if I feel like, physical therapy may be helpful, I'll put them through that. And, it's really important to use these therapies early. It's a myth that you use these therapies later in advanced disease. No, if I see that somebody is having some balance issues and they're not treated, say, let's treat you, you'll get better, let's go and do some PT and start doing your physical therapy for life. If I think the speech volume is low, I send them to, Samantha. If they don't want to go, I'll say, go to Parkinson's Voice Project, 10 a.m. I cannot tell you how many people I have in various parts of the world that I've got them hooked onto Parkinson's Voice Project, 10 a.m., whatever time it is in your country. And especially I have a couple of Indian, patients who are parents of my friends. And I say, okay, so 10 a.m. is basically 9:30 p.m. in India. Eat your dinner, do everything. log in and do your exercises, do your speech exercises, because, LSVT or Speak Out is not available in India. It's not available in all countries. And then I'll send them to, skin cancer screening. So that would be something I might say, because Parkinson's patients have a higher incidence of melanoma. And that's really my new, patient visit. Then I give them opportunity to, ask questions. Now that we have so many resources, I tell them about Skypass YouTube channel. They can watch videos. I tell them about DAPS, Samantha's lecture series. I give them, Michael J. Fox Foundation and the 3 things that we do in town. I tell them about them so that, they can go and read more. Of course, I tell them the more you're going to read, the more you're going to scare yourself. Write your questions down, bring them at the next visit. Okay. I'm going to stop in a few minutes, but I just want to say a couple of things to add for if you're going to come in for a follow-up visit. So follow-up visit for me is 30 minutes. Please, I tell patients you have to be there 15 to 20 minutes ahead of time, because my medical assistant has to weigh you, get your blood pressure, get your blood pressure, with sitting and standing to see that the blood pressure is not falling. That's orthostatic hypotension, drop in blood pressure with changing positions. We need to check for that. Your medications list, need to reconcile all this. This takes time. If you show up for your 8 o'clock appointment at 8 o'clock and 15 minutes are gone, I'm only left with 15 minutes. And as nice as a person I might be, I have to see other patients. I can't make, patient number 2 and 3 and 4 late because you showed up late. So, now, do I run late? Yes, I run late. Why do I run late? Because I spend a lot of time. Okay, so it sounds like double standards that I tell my patients, you can be late, but I am late. And I'm late only because, I'm taking the time with every patient. But when I'm in the room with you, you're going to get your time. You're going to get all your questions answered. You're going to walk out, if you came on time, you're going to walk out with a full visit. For a follow-up visit, I really need, to know a couple of things. So I need to basically know, since the last time you were seen by myself or my PA or my NP, what happened? Is everything the same? Has anything worsened? If you were diagnosed with something, I don't necessarily have the time to listen to, like, oh, I got diagnosed with this cancer and I went to chemo and then through all that, but if you were diagnosed with melanoma, then I'm interested in knowing. But even if you're diagnosed with congestive heart failure, I want to know. I just cannot listen to a lot of details. I do recommend to patients that please do tell me if you are diagnosed with something else in between the visits, because if you are diagnosed with congestive heart failure and my medication retains fluid, I'm not going to give it to you. It's dangerous, right? So it's important that you tell me what all happened in your medical history from the last time that you saw me. So you can tell me if you're diagnosed with something else. People will say, oh, my medicine's is working well, but it's wearing off in between doses. So important things, do you take your medicine empty stomach, especially the levodopa, carbidopa, with full glass of water, 8 ounces or more? You wait an hour or so before you eat anything, especially protein, but anything. Some people that have nausea, vomiting, I'll let them eat, the medicine with crackers or with fruit, and then, make sure you're managing your constipation. These are the questions that I'll basically ask. If any new non-motor symptoms happen, or if you started falling and you were not falling before, I need to know that. So it's really important to you just write all of these things down and bring your story to me, not start thinking about it when you're sitting in the chair, because you may not remember everything. So write down everything that you want to talk, sit down and write down the things that you want to discuss at the visit. Now, if you come with a list of 10 things, I may say, okay, let's prioritize. Let's talk about the ones, if you're falling, I want to know. If your medicine's not working, I want to know. But, maybe we can talk about managing your constipation at the next visit, or talk to your primary care doctor, or we can talk on my chart, or so on and so forth. If I have time, I'll address it. Important things that you really need help with. So before you leave my office, what is it that you would like resolved? I think that's really important. Now, for basically patients that are coming in for a new diagnosis, confirming diagnosis, but if you're coming in for a follow-up, if you had any test, hey, Dr. Chitnis, you had asked me to get a brain MRI. I did it outside because I live, an hour and a half away. I'll, give it to the medical assistant, load it, take a look at it. I got started on a new medicine by my primary care doctor. When you get medicines, I need really details. Like, for example, I want to know I'm taking levodopa, carbidopa, like Cinemet. I'm taking 25/100. I take at each dose 1.5 tablet. I take it 4 times a day. Every 4 hours, my approximate timings are 8, 12, 4, and 8. and I eat like at 9, 1, 5, or my snack at 10 o'clock or something like that. And so that's really important. Or I take Azilect 1 milligram per day, or I take amantadine 100 milligram 3 times a day, or I take Inbrija inhaler, or take Kinmobi, whatever it is. Every single medicine, dose of the medicine, what time you're taking it, how many times you're taking it, write it down, just put it on a piece of paper so I can look at it. So many people keep really good logs. I can't tell you how easy it makes my life and how much I can help you, because I know exactly what you're taking. Follow-up visit. So now we have my chart and you can pre-check. There's a lot of times you can pre-check, you can go and reconcile your medications, you can add new diagnosis. And I highly recommend that pre-check in before the visit. If I have to go to any doctor's visit, I thankfully don't have a lot of doctors, but to go to a doctor visit, I just pre-check in. Because I know, being a physician, how valuable my doctor's time is, but I also want to get the best bang out of the buck. So even I write things down and say, I want to talk about this, this, and this. And so then I still do the exam. I still ask you about non-motor symptoms. What I'm starting to do now to make things, because I like detail. Like, I want to know everything about you as a patient. I want to help you with everything that you have, but I have 30 minutes. So, I'm starting to, I print out a non-motor symptom questionnaire and I give them to the patient and I say, fill this out, and so when they fill it out, then I can see what their issues are. And that way I can talk about those issues. So I'm starting to do that, hopefully we continue to do that. But, unfortunately, the MAs are very busy. So they don't always end up giving that form to the patient when they're sitting in the waiting area. Then I have to give it to them while they're in the room with me. And that's not most efficient. But, the more and more I might put this as a pre-check form so that you can do this at home, you can check in. So when I see you, and, I do my pre-charting too. I look at the chart and I look at, especially for news and follow-ups, I'll check and see who do they see in the meantime, what have they done. So, I'm still informed. Like, I'm not like, I have no idea what happened. I like to pre-check my charts and know so that I know what you did at the last visit. I can pull up, thankfully, we have electronic medical records. Okay, so medication list, what do you want to talk about? Any side effects of medicines? And no question is a stupid question. I mean, I ask a lot of stupid questions. My husband about finances that I know nothing about it. My husband answers them. He rolls his eyes a couple of times, but at least answers my questions. So, bring your questions to me. I'm here to, to help you with that. I think I covered. And then when you leave, here's the important thing. Keep track of your prescriptions. Okay, if you have 1 week left, you need to give us 1 week, to be able to refill your prescriptions. How many people ask us for refills? How many MAs we have, how many nurses we have. It's like, and we are in the pandemic era. It is really hard to hire good people. It's really hard to, if I'm paying somebody $15 an hour and somebody pays them $20 an hour, they're gone. So it's tough. So I think that the more we optimize, the more you optimize your visit, I think that, it's great for you. It's great for me. And I think I pretty much did cover, everything. So, again, ask me for scripts early, ask me for therapy orders early. And then that way, it helps. Now, if you know a place where you go, I go to Baylor Rehab and it's in Richardson, bring me the fax number. So that way, Michelle doesn't have to spend, Michelle's my medical assistant. She doesn't have to, spend a lot of time trying to look for that. She's very efficient now. She has all of this, at her fingertips. But if the easier you make my life, the better I'm going to be able to take care of you. And it's going to be a more comprehensive visit. And I think that, Shelley, is, let me make sure. Interval history, what happens since you last seen, new events, new diagnosis, Parkinson's symptoms, medications, side effects, any other symptoms. What do you wish to accomplish at this visit? Therapy, refills, general counseling that I provide, routine health maintenance, of course, exercise. If you're not exercising, what I'm telling my patients now, my magic number is 5. Okay, if you're not exercising, I'm giving you 3 months. If you're not exercising, cancel the visit. Don't come. Not because I don't care about you, because you're not doing what you're supposed to do. Do your speech exercises. You have no excuse. Do you eat every day? Then why don't you, do you want to continue to be able to, when I ask these questions to patients, sometimes they go like, huh? Like if I say, do you eat every day? And they're like, huh, of course I eat every day. Why don't you do your speech exercises every day? Would you like to continue to swallow and eat and be healthy and not choke and not aspirate? So, I think accountability, I think accountability is bi-directional. That's going to be my last word. You got to make your physicians accountable. I like to be made accountable. I want to make sure that I'm providing the best care for you. If I'm not, I need to know. And why not? I'll correct the things I can correct. Of course, there are some things that are beyond my control. I don't have my own practice. I work for a university. And then driving safety, really important. I don't like to arm wrestle with people that you should not be driving. Let's all use our common sense to recognize what's safe for us, what's not safe for us. And I understand, driving is something that people don't like to give up, but your safety is paramount, and the safety of everybody else on the road. And then, I don't check labs. I'm a Parkinson's doctor. I'm not a primary care doctor. I don't really check labs, but I do want the primary care doctor to check vitamin D, calcium, and B12. Vitamin D and calcium, bone health, advanced PD, fall risk, vitamin B12, levodopa interferes with absorption of B12. If you have a low B12 level, we need to correct it. If it's normal, we don't need to do everything, but check it a couple of times out of the year. And then we talked about skin cancer for melanoma. And that is all I have. And Shelly, I'll share my my document with you so that you can share it with everybody. Okay, all right, bring them on. Bring me your questions.
Okay, guys, I hope that was helpful. And as Shilpa said, we will be sending that document out. I got some questions with registration, so we'll start there. But if you guys have questions, get them ready. You can either put them in the chat box, or if you want to verbally ask them, I'll open it up here in a second so you can just verbally ask your question. But let's just start off with this one that we got with registration. Shilpa, any special tips for care partners outside of what you outlined? Any special tips for care partners to help make the visit go smooth? We got a couple of questions. I'm going to read off one that kind of represents the general sentiment I think that a lot of care partners have. As a caregiver, I'm getting pushback from my spouse, who's the person with PD, about wanting to ask questions about troubling behaviors, such as out of control emotions at times. Any tips on how to deal with that as a care partner?
Yeah, so sometimes people will send me a my chart, and say, especially if the care partner spouse is doing my chart, I'll get a message from them saying, hey, Dr. Chitnis, I want to let you know about this, but I don't want Mike or Steve or whoever to know about it because he's going to get upset. Sometimes what I encourage people to say is, sometimes people will step out to go to the bathroom, and then they'll say, hey, Dr. Chitnis, can I ask you something really quickly? And I'll step out with them, and then they'll say, hey, I wanted to tell you, so there's various ways. I mean, you could send me a my chart message, or you could just basically, take me outside of the room and we go to another room. We don't have those many rooms right now. Go to another room and say, hey, I want to talk to you. So, you can communicate to me. I don't suggest that you send me an email. My email is very easily available. The university does not encourage, emails they want us to do my chart, but you can certainly, or sometimes the patient goes to the bathroom and the spouse is so relieved because they have all these questions that they want to ask, So just tap me, tap me on the shoulder and make me some gesture that you want to talk to me later, and I'll figure out a way to send the patient away and talk to you.
Does anyone on here have a question? I want to give live attendees a chance to ask. We do have a list of questions that came in with registration, but I'll just pause there. Does anyone have a question? If so, you can put it in the chat or unmute yourself and ask.
I don't know how to do it.
Sharon, I think we can hear you.
Oh, great. Thank you. Thank you so much. My husband's a 10-year plus Parkinson's patient already, and he is coming to see you on March the 23rd. We are so thankful. We've been waiting for months to get in. And we did things backwards. We saw another doctor in surgery at Southwestern today, but he was very kind and very helpful. Right now, my husband, as you can see, he's having a lot of pain with dystonia. I think it's been diagnosed as that. I mean, from the physical therapist that helps us, etc. But anyway, can you make any suggestion that might help? The doctor today said something like, maybe his meds were off when it's hurting him. It doesn't hurt him all the time, but like right now it's very painful, but he had his meds on time. So I don't know, we're just kind of at a loss.
Yeah, when is your appointment?
It's not till March the 23rd, but we're just waiting to see you.
Okay, well, firstly, that I'm really sorry that you guys have to wait long. The reason for that is, there is only so many of us. And, I'm in academic medicine. I really see patients only 5 to 6 half days. The rest of the time, I'm either writing papers, doing research, teaching. So I don't, that's part of the reason why the wait times are so long. I think that dystonia, so the pain you can have two things. So when the medicine wears off, then the toes can curl, and that's dystonia. So you have to make sure that you want to make sure that the medicines, really, you take it on an empty stomach, full glass of water, wait a whole hour before eating anything, and not be constipated. So that will absorb, as much of the medicine that needs to go into the brain. And then you need to make sure that, how long, keep a diary, like how long does the medicine last? If you're taking medicines every 5 hours and it's lasting only 4 hours, then you have that 1 hour where the poor patient is off and having dystonia and then having pain. So you need to basically, try to maybe move the medication, a little closer, which means that you may end up adding an extra dose at the end of the day. The dyskinesia, so dystonia can be off dose, which is when the medicine runs off. The dyskinesia can be peak dose, that is, but can be peak or off dose, but mostly peak dose. So, where they're having a lot of, involuntary movements.
Yeah.
So either, I mean, the many strategies, you can reduce the individual dose of the medicine. There is certainly, amantadines and other medicine. And I suspect you saw Dr. Puratian or Dr. Lega for DBS, right?
Yes,
That's
we
who you
do.
saw. Yeah. Yeah. Well, we'll see. I'll take a look at your chart and I'll try to see, I don't want to make promises I can't keep, but if we have a cancellation, I can bring him in sooner.
Okay.
We'll try.
We just appreciate anything. We've dealt with it for a long time, but it's
Well,
just,
he's gonna get help. I promise you. If
Yeah.
you saw Dr. Puratian, right?
yeah, we're real
Okay.
thankful. Yes, we did. We saw, how do you pronounce it?
Nader. Puratian. Yeah.
Yes. So
Yeah.
nice.
Don't worry. We'll
Okay,
we'll
thank
help you.
you.
Okay.
We
Sorry
enjoyed
for
it.
the
Yes,
delay,
thank
but
I'll be prepared when I come in. I took notes. Okay.
okay.
All right. Thank
Very good.
you. Thank you.
Most
Thank
welcome.
you, Sharon, for your question. Anyone else have a question? Okay, let's go to one that we got from registration. Let's see here. Is it harmful to the patient if they delay meds after a diagnosis? The symptoms are minimal due to exercise. So how long can someone hold off on taking levodopa?
Yeah, good question. So, in the past, when I was in med school, I still remember, I was a third year med student at Grand Medical College. The beds, they had no beds there, the patients on the floor, really, like, and diagnosed with Parkinson's. And I still remember how that was. And that era, we used to say, you have Parkinson's disease, you don't seem to have a lot of, impairment in your functionality. Go away. When you start to have some, problems, things you can do, come back and we'll treat you. I think there has been a little bit of a paradigm shift. I mean, there are still patients who will say to me, I'm very mild, I don't want to be treated. And I'll respect their wish, but my general approach is to treat them. So if they're very mild, then I might treat them with a milder agent, such as a monoamine oxidase B inhibitor, such as Rosagilin. It's 1 milligram only taken in the morning. And, there is at least, I know that there is one paper that came out, and I, always fixate on that paper, which basically showed that the body has some compensatory mechanisms. And imagine that by the time you become symptomatic with your first symptom, you've actually lost about 40 to 50% of the nerve cells that make dopamine. So you've lost almost half of your quota of dopamine in your brain, and the body has compensatory mechanisms, and that's why you were not symptomatic in spite of that. So I think that if treated early, there is some evidence that the body's compensatory mechanisms may be preserved, and hence it may be important to treat. My general view is to treat. If I'm, if I'm pretty confident of the clinical diagnosis, or if I get a DAT scans positive and they clinically look like Parkinson's, I'll start them on 1 milligram of Azilect. If they are symptomatic, really, where they can do, I can't do this, I can't do that, I can't whip eggs, then it's just depending on the severity of these symptoms, I decide whether I should start them on Azilect, or should I start them really on some form of levodopa carbidopa, which can be Sinemet, or it can be even Rytary, the long acting. Is there any harm in delaying treatment? I don't know that there is any harm in delaying treatment. I mean, it's not like, that you would die faster if you weren't treated. But I think, that my sense is that if I'm sure of the diagnosis, I recommend for people to start treatment, So most of the times when I have some people that are very mild, I'll say 1 milligram of Azilect, as long as it doesn't make a hole in your pocket, as long as there are no drug interactions with medicines that you're taking, and then exercise. Make exercise your friend. So, my young onset people, they don't get a pass. They have to figure out a way to exercise 5 days a week. Whatever you do, 5 days a week, something you got to do, and, exercise. So don't start smoking. If you start drinking coffee now, it's not going to slow down the progression. There is some data that to suggest that if you're a caffeine drinker, then maybe it protects you against developing Parkinson's. But I know enough people who drank caffeine all their life still develop Parkinson's. But the long answer to your question, Shelly, is that there's no harm if you want to delay treatment for a little bit. I know Dr. Espe, who's an world-renowned movement disorder neurologist at Cincinnati, sometimes will say, okay, all right, well, go exercise, go get good sleep and nutrition, and I won't treat you, come back, but really, I think that there is merit in starting treatment early.
Got it. Thank you for that. Here's a question that we got in chat. Have you noticed, Shilpa, if there is a Parkinson's profile, or in other words, a suite of common personality traits that people with Parkinson's have?
Yeah, I mean, have I noticed it? Maybe sometimes, but I've read it enough in textbooks or in papers that, that people with Parkinson's, they, for whatever reason, become more reticent, don't want to get out as much, want to stay more kind of isolated, end up becoming a little bit more rigid than they were before. Like, if they were more flexible, now they are like a little bit more rigid. But it depends. I don't think I can generalize. I've seen that happen to some people, and they say, like, the Parkinson's personality sort of say certainly can be like, more reticent, quieter, rigid, isolating. It's quite possible.
And as a follow-up to that, have you seen patients that follow a vegetarian diet that seem to do particularly well? Or if you have patients who follow a vegetarian diet that seem to do better than those that have a non-veg diet?
Not really. I mean, I think that, even the ones that do a vegetarian diet, I have to encourage them to eat protein. You cannot stop eating protein. I mean, you have to wait a whole hour, after you've taken your medicine before you eat protein. Or if you ate protein, sometimes people will wait almost an hour and a half. Sometimes I'll tell patients to eat protein at the end of the day. I don't, from a cardiovascular standpoint, is a vegetarian diet better? Like not eating red meat, or not eating, shrimp, is that better? Maybe that is, but I don't see that, that one does better than the other from a Parkinson's standpoint. I think that the interaction between, meals and medicines or protein and medicines is something to pay attention to. I personally really like the vegetarian diet, but then those people have to eat some form of protein, whether you're eating lentils, whether you're eating tofu, whether you're eating some kind of beans. But because you cannot lose protein, you're going to lose muscle mass. I mean, you do need protein even if you're vegetarian. Does that answer your question?
Yes, absolutely. So in other words, I guess the short answer is there is no major difference that you've seen with patients that follow the veg diet versus not.
No, I mean, and then there is if you read nutrition and Parkinson's, there's so many diets that they have looked at. I mean, certainly Mediterranean diet, the MIND diet, but there is like no. I think that my suggestion is eat like I think Mediterranean diet is great. I mean, what Mediterranean diet means is that there is lots of salads, there is lots of fruit, there is a lot of lean meat. That there is so that's what it really means. I mean, don't eat a lot of baklava, but I think that's what it really means. Grains, whole grains, veggies, fruits, lean meats, fish. That's a really good diet for everybody.
Got it. Here's one. Can antibiotics interfere with the efficacy of Parkinson's disease medications? My husband's off times increased for a week after he had a dental implant appointment.
Yeah, so people that develop urinary infection or people that develop respiratory infections, they certainly and take antibiotics, certainly end up, because of the illness and because of the antibiotics. It appears, I don't think that they affect disease progression. I think that what happens is that your overall constitution changes, that you're sick. Also, I think antibiotics also do affect the gut microbiome. And so, that can cause problems with absorption of the levodopa. And so I think that anybody that is on antibiotics, I would really bone up on probiotics. But there is, be aware that if you are on antibiotics for a urinary tract infection for a period of time, your Parkinson's disease, may appear to be worse. But, once you're off the antibiotics and you're cured of your UTI, you'll go back. I mean, the older you are, the longer it takes to come back to the baseline. But I don't think that your baseline should really shift, that there's progression, that taking antibiotics caused your disease to progress. It's not like that.
Got it. Here's one that we got in chat. Really great question. Is there any research on visual motor deficits with Parkinson's disease? And why is vision not a part of the doctor's screening? And why don't they recommend visual exercises just like they do voice exercises and physical exercises?
I think this is a really great question. I did mention to you guys that I always check eye movements, right? I check eye movements in new patients. I check eye movements in patients in the first 5 years since symptom onset. I think this is really important. Patients with Parkinson's disease will complain of visual complaints. They compare of, blurry vision. They can complain of convergence, insufficiency. They have really, the yoke movements that need to happen. Look to the right, look to the left, all of those things can slow down. So I agree. I think we should really pay attention to, to visual as well. There is, maybe the ophthalmologist can tell us about, any eye exercises that can be done. We're not doing anything right now, but yes, the eyes are involved, the oculomotor system is involved with Parkinson's disease for sure, without a doubt.
On that note, Shilpa, are there any specific visual exercises that you know of or that you recommend?
Not really. I don't know of any exercise, but what I tell people is basically just do these, look right, look left, look up, look down. It's essentially just how you do your, arms and legs. And, I don't recommend anything like that specifically. There are some patients that benefit from prisms. I'm going to ask my neuro-ophthalmology friend if she can come up with some exercises. I don't, maybe this is an opportunity for us to start developing some exercises, that maybe the patients can do. But, fatigue, eye fatigue is really big part of the disease as well. So, this is good opportunity. I need to talk to my neuro-ophthalmology friend to see if there is any, I don't know whether doing exercises will cause improvement really of those issues, because all of those things are related, I think, to, dopaminergic deficiency as well. So if we optimize, the dopaminergic treatment, maybe they be better, but that's a really good question. And I will promise to at least, see if we can work on it.
Great. We just have a few more questions. I know it's 8:05. Just hang with us or jump off if you need to. Shilpa, just a couple more questions. I want to make sure we.
Yeah, I'm not jumping off. I'll stay.
Here we go. Let's see. You addressed that one. Okay. Are there any key, and we may have addressed this already, but are there any key tactics to prevent freezing? How much exercise and PT and walking should I try to do every day? And I think you spoke briefly to that, but anything else you want to add?
Yeah, so there is two kinds of freezing of gait. There is a off-dose freezing of gait, which is I took my medicine at 8 o'clock. My medicine was due at 12. I was outside, with my friend out to lunch. I missed my dose. It's 1 o'clock. My medicines wore off. Now I'm freezing. That is off-dose freezing. Off-dose freezing is very easy to treat. Don't forget your medicines. Keep a diary. Make sure that the medicines are, there is like a smooth transition between dose 1 to dose 2 to dose 3 to dose 4 to dose 5, whatever number of doses you're taking. As long as you're making sure, because remember that it takes the medicine, if you're doing everything correctly, if you're taking it on an empty stomach, full glass of water, not constipated, and waiting an hour before eating anything, I keep belaboring this, it still takes about anywhere between 15 to 30 minutes for the medicine to kick in. So, so basically, if you took your medicine at 8 and your medicine is wearing off at 11:30, then maybe you need to, take it, or it's wearing off just before 12, then maybe you need to take it every 3.5 hours, or you need to be converted to the, the long acting Rytary. So that's freezing of gait that happens off dose. There is on dose freezing of gait, which is very difficult to treat.